not be approved yet.
Thank you, sir.
So shall we move on to the summarization part?
Yes, sir, we can.
So I'll share the screen. I will be jotting down things, and if it's not visible or clear, kindly interrupt. Okay. Yeah. Am I audible?
Boss, you are audible and visible as well. So you
Okay. So
can
you are saying
turn
that what you can see is that board, no, whiteboard.
whiteboard plus you, both the things. I
So
think.
both are visible. Okay. Okay. So
So
we'll be
I
starting with
think I have pinned you up, so and you are visible to me.
yeah, yeah. So
Okay,
we'll
right.
just try to summarize it quickly. So starting with the dementia, what I need everybody to recap is dementia is basically your decline in memory and intellect, memory as well as intellect, in which multiple cognitive domains are usually affected. Okay, multiple cognitive domains are usually affected. It is not the deterioration or decline in memory alone. There are other cognitive domains also affected. Now you distinguish it from distinguishing is from neurodevelopmental disorders, NDDs, like intellectual disability, MR, autistic spectrum disorders, ADHD. Here also you have got impaired cognitive domains, but they are generally congenital or manifesting in the early childhood, whereas dementia is supposed to be acquired at a later stage. And you also distinguish it from delirium. You distinguish it from delirium by the course and prognosis and the weightage of the cognitive decline. That means in delirium, attention and orientation is disproportionately affected, while in dementia it is multiple, memory, learning, all those things are affected. So you have to delineate and distinguish between these disorders. Okay. Now the second most important aspect of dementia that one is supposed to remember is the confusing part, that is your nosology. Nosology, like you have got ICD, a different system of naming and grouping dementias, and in DSM-5 you have got a different system of naming and grouping dementias. In ICD-10, it is grouped under the broad heading of organic mental disorders. So in ICD, you have got organic mental disorders, and under that you have got namings like dementia. Oh, sorry. Dementia in Alzheimer's disease. Okay. Dementia in Pick's disease. Dementia, similarly dementia in Lewy body disease. This is how you name and group dementias in ICD. And this can be mild, moderate and severe. Then with oblique, without behavioral symptoms. This is how you group and name dementias in ICD. Whereas in DSM, how you group and name dementias is under the broad heading of major, oblique, mild neurocognitive disorders. Okay. So mild neurocognitive disorder, usually it is not subgroup. Why it is not subgroup? Because at the stage of mild neurocognitive disorder, it is not possible to distinguish or establish whether it is due to Alzheimer's disease or frontotemporal disease or due to Lewy body disease, because the symptoms are mild and vague. So at the stage of mild NCD, you usually do not specify whether it is due to Alzheimer's or due to frontotemporal disease. But major neurocognitive disorders, how do you name them? This is major neurocognitive disorder due to Alzheimer's disease. It can be major NCD due to frontotemporal dementia. Okay, so this is how you name and group them in DSM-5. Mild NCD can also be named in a similar fashion if you are able to find out the cause, underlying pathology of this mild NCD. So it can be mild NCD due to Alzheimer's disease or mild NCD due to frontotemporal disease. This is how you name it. This is just for the sake of understanding the nosology. The third part, other than for DSM and ICD, there are some other, group. Namings which are used and which causes confusion. And most important of them is MCI. MCI. What is MCI? MCI is mild cognitive impairment. Mild cognitive impairment. This term is not as such used either in ICD or DSM, but this is a very commonly used term in psychiatric practice. This is when you have got certain symptoms of forgetfulness and all, which is not severe to cause a impairment or curtailment of independence, but still these are neurocognitive symptoms of concern, which occurs in excess to what is expected in normal aging. So that is when you use the term MCI, and MCI can be roughly equated to mild NCD, which is not clear due to which disease it is occurring. So mild NCD is almost equal to mild cognitive impairment. All right. So that is how you name the dementias. So two different systems of naming, ICD and DSM, and then certain aberrations like MCI, which comes up, which is not part of integral part of ICD or DSM. And the other thing that one must remember is the term dementia has not been done away with in DSM fully. It has been subsumed. So the word dementia or the terminology of using dementia is still valid even under DSM. Okay. So after remembering or recapping the nosology, what we need to recap is the activities of daily living. Activities of daily living. One need to remember that there were two of them. One is basic activities of daily living, BADL, and instrumental activities of daily living. Basic activities of daily living, to summarize, they are like feeding, dressing, ambulation, toileting. These are the basic activities of daily living. And instrumental activities of daily living, they are like transportation, hiring a cab, driving, or handling money, handling your instruments. So they are the instrumental activities of daily. And depending on the loss of these activities of daily living, you classify the dementias, whether it is mild, moderate, or severe. You actually look. So whenever the BADL they get impacted, then you can call it as a severe dementia. The person is unable to care and there is total loss of independence. Whereas when there is only impairment in the IADL, it is mild to moderate dementia. So that is the importance of BADL and IADL. Why is it important? Because loss of independence and loss of function, that is an integral part, very important part of diagnosing or managing a dementia. So that is about activities of daily living. Now the next thing that we need to remember again, bring up again, is the etiologies of dementia. So in the etiologies, one has to remember all the reversible causes of dementia. Reversible causes of dementia, rehash it. What were they? They were normal pressure hydrocephalus, hypothyroidism, hypercalcemia, then nutritional deficiencies like vitamin B12 deficiency, folate deficiency, then you have got Wilson's disease, HIV. They are HIV and Wilson's disease. They are not reversible, but the dementias which happen subsequent to them, they can be reverted or reversed with appropriate medication. So these are the reversible causes of dementia. One has to keep these in mind and then look out for these reversible causes so that you can treat and reverse the dementia. Okay. And then coming to the actual etiology, the classification of etiology, the most important chunk of dementias is due to neurodegenerative diseases like Alzheimer's disease, frontotemporal dementia, also known as Pick's disease. Then you have got dementia with Lewy bodies, Parkinson's disease dementia, and so on, like Huntington disease dementia. They are all neurodegenerative disorders. The second most important etiology of dementia is vascular. Okay, so basically vascular dementia is second most common. Among them you have got infarctions in your cortex and also your Binswanger disease. Binswanger is subcortical infarctions in your white matter. Okay, so you have got two of them. One is due to widespread infarctions, multiple small infarctions in your cortex, and the second one is your Binswanger. Binswanger is in your subcortical white matter. So these are the major signs of dementia. Almost 60% of your dementia is because of Alzheimer's disease. And next common is your vascular disease. And third most common is Alzheimer's combined with vascular. Alzheimer's and vascular, they often occur together. And then you have got frontotemporal dementia, Lewy body dementia, and PDD, Parkinson's disease dementia, in that order. Okay. Other than that, there are other rare causes of dementias, say like chronic illnesses, renal failure, hepatic failure. Everything can give rise to dementia. But when you actually deal with dementias, you are actually dealing with neurodegenerative diseases or your vascular diseases in particular. Okay, so after recapping these etiologies, now you come to the different types of dementias. So you have to remember the major features of Alzheimer's dementia, frontotemporal dementia, dementia with Lewy bodies, and vascular dementia. At least the broad differences between each. Like in Alzheimer's dementia, you are this is your brain. So this is your brain. In Alzheimer's dementia, which areas are affected? It is basically your temporal lobe and your parietal lobe, which is affected in Alzheimer's dementia. So you will have defects in temporal function and your parietal function. So basically memory problems, aphasias, language problems, they will predominate. In frontotemporal dementia, the main areas affected, they are your frontal lobe and your temporal lobe. Okay, and in Alzheimer's disease, which part of the temporal lobe is most affected? It is the mesial temporal lobe, that is the medial part, hippocampal gyrus and your entorhinal cortex. Okay, just for your remembering, just to recap these things, Alzheimer's dementia is basically temporoparietal, whereas frontotemporal dementia is frontotemporal. Okay, so you will have problems with your personality, your social inhibition, that is the frontal part, or you can have problems with your language and memory. So that is how frontotemporal dementia goes. Then you have got Lewy body dementia. Lewy body dementia, now I am giving you a coronal section of the brain. This is up to the midbrain and this is the cerebral hemispheres. So what we need to recap is the difference between Parkinson's disease dementia and dementia with Lewy bodies. In PDD as well as DLB, you have got the same bodies which are getting deposited. Like Alzheimer's disease, you have got plaques, extracellular plaques and intracellular neurofibrillary tangles. In the same manner, in dementia with Lewy bodies and Parkinson's disease dementia, there is a common deposition. That is alpha-synuclein deposits. Okay, so dementia with Lewy bodies and PDD, microscopically or in a biochemical sense, they are the same. How it differs is in the distribution. In dementia with Lewy bodies, you have got these deposits primarily in your cortex, in the cerebrum. Whereas in Parkinson's disease dementia, these deposits, they occur mainly in your midbrain part, in your midbrain and your lower centers. Okay, so that is how the difference happens. So in dementia with Lewy bodies, you will have primarily cognitive symptoms. And when it progresses, when the dementia with Lewy bodies it progresses, it also leads to some deposits in your midbrain, and your movement symptoms can accompany. It can come up later. Okay, that is how dementia with Lewy bodies progress. Whereas in Parkinson's disease dementia, this alpha and synuclein, it is getting deposited first in your midbrain. Okay, so it starts with movement symptoms, and later the deposits, they can keep happening in your cortex. So you will have cognitive symptoms as well. So it is basically the question of which comes first, whether cognitive symptoms come first or the movement symptoms come first. There is actually more to it. Even in dementia with Lewy bodies, movement symptoms can manifest first, but the cognitive symptoms have to accompany and manifest within 1 year. Okay, whereas in Parkinson's disease dementia, you generally have got movement symptoms first, and the cognitive symptoms come several years later, more than 1 year later. That is the broad difference between DLB and Parkinson's disease dementia. And speaking about dementia with Lewy bodies, the thing that we need to remember, the issue that we need to remember is DLB is a very atypical kind of dementia. It can have delirium features, delirium-like features like fluctuating cognitions, and it can have psychotic-like features of visual hallucinations, auditory hallucinations, delusions, all those things are present. And finally, dealing with vascular dementia, typical features of vascular dementia is that it has got a step ladder kind of a progression. So there is a deterioration after a stroke, then it remains good for some time, then another stroke happens, then again your cognition dips, it remains same for some time, then again you have another vascular event, so that there is a general step ladder like deterioration of symptoms. That is the course of vascular dementia. This is a general picture. Other kind of declines can also happen, but this is a typical picture. Also in vascular dementia, you can have mood symptoms. Depression is also a part of vascular dementia commonly. Okay, so these are the important dementias, individual kind of dementias that one is supposed to know a little bit about. And after that, what are you supposed to know or supposed to remember? That is the difference between cortical dementias and subcortical dementias. Like cortical dementia, all these dementias which we mentioned now, except for Parkinson's disease dementia, they are all cortical dementias. And subcortical dementias are those dementias in which primarily your subcortical nuclei, they are getting affected. Okay, like in Huntington disease or in Parkinson's disease. Huntington disease, you have got involvement of your subcortical nuclei in the striatum and all. And in Parkinson's disease, your midbrain is affected. Okay, so that is how you distinguish between cortical dementias and subcortical dementias. And there will be telltale signs of cortical dementia. Cortical dementia like Alzheimer's dementia or frontotemporal or Lewy body dementia, it will manifest with problems in which memory is badly affected. Language is badly affected. Then there can be significant deterioration in your cortical functions, say like agraphia, alexia, all these are all cortical functions. Agnosia, these things, they can also be significantly affected. Whereas in subcortical dementia, it is basically your recall rather than your entire memory spectrum which gets affected. Then language is largely preserved. Then calculations are largely preserved. Acalculia does not happen. Then mood badly affected in subcortical versus cortical dementia. Usually, this is the usual picture. Then speed of cognitive processing, that is again affected more in subcortical dementia. So you have to know the distinguishing features between cortical and subcortical dementia. Similarly, another thing that you are supposed to know is the difference between dementia and pseudo dementia. subtle differences, some differences, how to differentiate between an actual dementia and a pseudo dementia, which happens subsequent to a depressive illness. So you have to know the clinging features. Like in dementia, it is the caregivers who primarily complain of the patient's deficits, whereas in pseudo dementia, the patient will himself come and say that he is not able to think and function for himself. His mental faculties have been affected. And in dementia, the person, when you are subjecting the person to a neuropsychological test, the person will enthusiastically try to do. He will try to conceal his symptoms, whereas in pseudo dementia, the person will say that I don't want to go through this test. I am simply unable to, and then there won't be any effort. And there are